Hello, I am Tuya Pal. It is a pleasure and an honor to be speaking at this International Gynecologic Cancer Conference that is being put on through the Ovarian Cancer Research Alliance. I'm honored that the organizers asked me to speak. I will be talking about precision medicine, imprecise access, really focused on disparities in hereditary cancer testing. So what I wanted to start with is, why do we identify inherited cancer genes such as BRCA1 or BRCA2? And really the bottom line here is because we can save lives with this information. And I wanted to start off by providing a real scenario to demonstrate how identification of a BRCA mutation can really impact a family. So here we have a patient that I've seen in the past, Harvey. And again, the scenario is real, but the names are fictitious. So Harvey was 73 when I saw him. He'd had a diagnosis of prostate cancer at age 65 with subsequent bone metastases and breast cancer at age 67. He had 3 children, 2 daughters and a son. Now, Whitney, his daughter at age 45, got diagnosed with stage 2 breast cancer. The same day, the mother got a call from Missy, age 42, who had just been diagnosed with stage 4 ovarian cancer. Whitney got tested. You can see here she was BRCA2 positive. She subsequently had a double mastectomy. Missy also got tested, and not surprisingly, she also has the BRCA2 mutation that subsequently was determined to be inherited from her dad. Now, just as a quick refresher with inherited cancers, once someone has an inherited cancer gene mutation identified, that informs what type of cancers they may be at risk for in the future. So with BRCA1 and BRCA2, think about breast cancers, both in men and women, ovarian cancer in women, prostate cancer in men, as well as pancreatic cancer. And the whole purpose of identifying these mutations is to enhance care. So really through cancer risk management, including early detection, options for risk reducing, surgeries, as well as treatment consideration. And again, it's really important to remember that, yeah, we want people to get testing, but testing itself does not save lives. It's really acting on the information that can save lives. So let's think about if this family had this BRCA mutation identified 6 years ago and how that could have changed their lives. So here we see if Harvey had testing 6 years ago and identified to have the BRCA2 mutation, he potentially could have gotten personalized treatments for prostate cancer as well as breast cancer screening. Whitney could have had prevention or earlier detection of her breast cancer. And most impactfully, there would have been an opportunity to prevent ovarian cancer through prophylactic surgery or preventive surgery in Missy. So when we're thinking about ovarian cancer risk genes, about 1 in 4 ovarian cancers are caused by an inherited gene mutation. And there are well-established risks for a number of ovarian cancer genes, including BRCA1 and BRCA2, but there's other ones like RAD51C, RAD51D, BRIP1. We have the Lynch syndrome genes. PALB2 is also an ovarian cancer gene, and then ATM also slightly raises ovarian cancer risk. Now, knowledge of a genetic mutation impacts clinical care in ovarian cancer in several different ways. So when we're thinking about prevention, we have risk-reducing salpingo-oophorectomy, which is a fancy way of saying removing both ovaries and both fallopian tubes. And that lowers the risk of ovarian cancer by 90% or more. And in terms of treatment, there have been studies that have now shown that with PARP inhibitors as maintenance therapy, so one of them is olaparib, after surgery and chemotherapy in newly diagnosed ovarian cancer patients with a BRCA1 or 2 mutation reduced the risk of recurrence by nearly 70% and is now the new standard care. So again, it gives you a segue into seeing how this has really changed the landscape of how we treat ovarian cancer and how we improve outcomes based on the genetic test results. So at this point, it's been more than 30 years since the discovery of the BRCA genes. And when we think about how many individuals have been identified, we're thinking about 10% of adult females in the United States have been identified. And these testing rates are not equal across populations. The majority of testing has happened in individuals of European ancestry, with much more limited testing in other groups. And so I wanted to have this as a segue into, again, we need to raise awareness, provide more information about inherited cancers, and, give people an opportunity to learn more about this information and how it could be relevant to them. So about 15 years ago, we started something called our Inherited Cancer Registry, which is really to end the cycle of inherited cancer through research, education, and engagement. We currently have almost 8,000 participants in the registry, and through participation, we are able to contribute to the larger research mission, but we also keep our participants informed about additional opportunities, and it has been the foundation of multiple studies of our own to, again, move the field forward. And through iCare, there are a number of participant resources that we provide. We have a website that is searchable. We put forth biannual newsletters in which we, again, highlight changes to guidelines, because guidelines are changing at least once a year, and it is very hard to keep up with what the newest information and newest care guidance is. We also communicate directly with our participants as guidelines change to give them a heads up, and we are very active on social media. And a lot of the images that I'll show over the course of this presentation are pulled from our social media feed. So when I'm going to start off with some care delivery focused efforts. And when I think of delivery of genetic risk assessment services, first I think about how to identify individuals, how they access the testing and uptake of testing. And then the delivery of genetic counseling and testing services comes next. And then once that's done, delivery of follow-up care is incredibly important. So starting with identification, access, uptake. Now, this is a study that was published back in 2017, and it was based on information from almost 50,000 women. And the bottom line here is fewer than 20% of high-risk individuals with breast or ovarian cancer were tested, and most hadn't even had a discussion with their healthcare provider about testing. Now, more recently, there was another study published by Dr. Alison Kurian and her team at Stanford, and what they looked at was the probability of genetic testing over time of a number of cancer types. And what they saw was the testing increased. You can see in the yellow line, the testing rates increased over time, but it was still below 50%. When we know that almost every woman with ovarian cancer is eligible for genetic testing at this point, and that's been for quite a long time. What was also seen in this study is there were clear disparities among non-white populations. You see the curve at the top with the rates in European or white populations. And then just as a comparison, the orange is Black populations. And you see, while testing rates are going up, they're still lower in other populations compared to white populations. So there's definitely a disparity that exists. Now, we had done a study in Florida where we looked at young women with breast cancer, so breast cancer diagnosed at age 50 or below, and we looked at how many received BRCA testing. And we also looked at the uptake of the surgeries among these individuals. So this was a cross-sectional study. As I said, we had over 400 Black women, almost 300 Hispanic women, almost 900 white women. And what we saw is that there was a clear disparity. There were much lower rates of testing in Black women compared to Hispanic and white women. And even when we looked at other things that could have affected testing rates, this remained a significant difference. And when we delved deeper in this, what we saw is the biggest factor in receiving testing is discussing testing with the provider, which makes sense. But then when we looked further, what we saw is that white women were 14 times more likely to have that discussion with their provider compared to Black women. So again, there is a disparity here as well. Now, when we're looking at genetic testing disparities in ovarian cancer, and again, I pulled this image from our social media feed, what we saw is, this is a study that again was published by my colleague, Dr. Kurian at Stanford. And what she showed through her study is that in ovarian cancer patients, genetic testing rates were lower in Black women compared to white women. You can see the difference here. What was also seen is that insured patients had higher rates of genetic testing compared to uninsured patients. So again, there's definitely a disparity based on race. There's a disparity based on insurance status as well. Now, going back to policy, now the National Comprehensive Cancer Network guidelines, or NCCN guidelines, have been around for decades, and those are the practice guidelines that we use in the United States to direct care. And as I'd also mentioned, in the guidelines, the personal history of epithelial ovarian cancer at any age has been there for many, many years. What we added to the guideline is other types of ovarian tumors as well, because what we've been able to see through research over time is there are other types of ovarian tumors that also may be seen in other genes beyond BRCA1, BRCA2, and the ones that predispose to epithelial ovarian cancer. So again, really important to keep up with guidelines. It's not just epithelial ovarian cancers that we look for at this point. Now, looking at delivery of genetic counseling and testing services, what we were also able to show through our study in Florida of young breast cancer survivors across Black women, Hispanic women, and white women is that, again, when someone gets genetic testing in the United States, a lot of times they have not necessarily had full genetic counseling or seen a genetic counselor or a genetics health professional. So we wanted to look and see whether there's a disparity in terms of who is accessing genetics health professionals. And the bottom line here is we didn't see a difference. It was about 20% across all three groups of women. What we also were able to show is differences in the discussion when someone sees a genetics health professional versus not. And again, you can see here in this area right here in this column are the different discussion items that we say should be discussed before testing. And if one sees a genetics health professional over the course of their care, they're more likely to have that discussion. That was essentially what we were able to show. So that gave us an idea about we want to make this type of information more accessible to the population. So we started with starting to develop an automated tool for educational purposes to educate women or anybody about genetic testing and really focus on the components that should be gone through before testing happens. So again, these were based on guidelines and various adult learning theory. And really what we were aiming to do is raise knowledge and make sure that people felt okay with deciding about testing once they and they had enough information to do that. So again, I'm not going to go through this in detail, but there was a lot of iteration that went into developing this tool, and we made it as broad as possible, like so covering all forms of inherited cancer, not specific to one. And the way we chose to do it is an animated video with audio and text, and the content was 10 minutes. Some people want to know more. So it was an interactive tool with the option to learn more and to click to get additional definitions. So we tested this in our clinic population, and what we saw was that knowledge was raised across literacy levels. So that's what you see here. And the gap was actually closed, which was very satisfying to us. And what we also saw is most of the individuals in our clinic-based population felt informed and empowered to make a testing decision after seeing this interactive tool. We also did this, administered this tool in our registry-based population of young Black women with breast cancer. And again, we saw that we were able to raise knowledge, and higher knowledge was associated with being a college graduate and with income. But in people who'd had prior testing, higher knowledge was not associated. Which is a bit of a surprise because one would think that they would be more knowledgeable from the outset because they had the testing, but that wasn't the case. Again, I think that's telling us that perhaps a lot of people are not getting all the information we'd like them to get before they get tested. So again, educational tool is just one component of the risk assessment. So in my mind, when I'm thinking about a risk assessment, we want to educate, but we also want to collect information and provide an assessment so that people, we can tell people what to expect through the testing process, figure out if they are eligible, figure out how it could impact them, impact their family members, etc. So that is what we have built and studied. This is an example of an assessment. So all this to say, I think there are ways to make this information more scalable. So having more individuals have access to this information to make a decision about testing. We've also transcreated it in Spanish. And again, we've studied it, and the conclusion is it's user-friendly, and we do think this is a scalable solution. So we are looking to expand this. Now, I wanted to also put in a plug to the Ovarian Cancer Research Alliance's free genetic testing program, because I've talked about genetic counseling, but again, genetic counseling and genetic testing kind of go together. And again, this is a slide I got from them about why genetic testing, who should consider genetic testing, and how the program works. And I whittled it down to some of the bottom line. So it's available to individuals at high risk for ovarian or other gynecologic cancer based on either family history of cancer or a positive gene mutation, as well as a personal cancer diagnosis. And those eligible can order a free at-home genetic testing kit from Color Health, provide a saliva sample by mail, and get the results. So all of this can be done in the comfort of one's own home. And the goal of the program is to increase access to genetic testing, and if there is a genetic mutation, offer an opportunity for personalized care. So I'm going to go on to delivery of follow-up care. And when I'm thinking about follow-up care, I think of it in three sort of broad categories. One is treatment implications based on a positive result, then guiding cancer screening and prevention, so cancer risk management, and the third part, sharing results with family members. So when we're thinking about follow-up care and cancer treatment, cancer in and of itself, what that means is uncontrolled cell growth. And this can happen in many different ways. But when someone has hereditary cancer, their cancer develops through a certain pathway that is common across the others with the same gene mutation. And learning more about these pathways has led to development of drugs to treat hereditary cancers with certain gene mutations. And the example here, one of the prime examples here, is BRCA and the development of PARP inhibitors. We could also talk about Lynch syndrome and how immunotherapy tends to work really well in Lynch-associated cancer. So there are multiple examples of this as well. So thinking about breast cancer and disparities in clinical trials, what we know is Black individuals represent about 12% of breast cancers, yet only 3% of participants in clinical trials. And when we think of the PARP inhibitors for BRCA-associated breast cancer, again, there's really been limited numbers of Black women that have had the opportunity to participate in these trials that then led to the approval of these drugs. And yet, on the flip side, data does suggest that Black individuals are just as willing to participate in clinical trials as white individuals. And then when we think about disparities in clinical trials for ovarian cancer, a recent study that was published in 2022 showed that Black and Hispanic women are underrepresented in PARP inhibitor clinical trials for ovarian cancer. And that tells us that these trials don't accurately represent the population being diagnosed with ovarian cancer. And it's super duper important to have initiatives to increase diversity when we are testing these drugs so that it is relevant to all populations equally. Now, thinking about going on to follow-up care with respect to cancer risk management and using BRCA as an example. Now, when we're thinking about cancer risk management, primarily we're thinking about, for BRCA, screening to find cancers early and preventive surgery to prevent cancers. And for breast cancer, in the context of a BRCA gene mutation, really screening is the breast MRIs with mammograms, and there is the option for risk-reducing mastectomy. With ovarian cancer risk management, really all we have at this point is risk-reducing removal of the ovaries and the fallopian tubes because we don't have any reliable form of screening right now. But thinking of it, the question we really want to answer here, which takes a lot longer, is does it lower mortality? Does it save lives? And that's taken us a long time to figure out because what we've been able to see is that the incidence of cancer, or no, not even the incidence, it's the cancers are diagnosed at an earlier stage in terms of screening for breast cancer. But again, what we want to show is the mortality advantage. And those are the studies that are starting to come out, and the results look really promising. So this was a study by my colleague Kelly Metcalf, published in 2024, focused on BRCA1 and BRCA2 carriers. And what they were able to show is that preventive mastectomy in BRCA1 and BRCA2 carriers led to a less than 1% chance of dying from breast cancer. So again, it does look like this surgery is saving lives. The other reassuring, some other reassuring studies that came out in BRCA1 and 2 carriers is the use of MRI. Again, MRI was shown to lower the risk of death, so MRI screening for breast cancer, and then preventive surgery to remove the ovaries and the fallopian tubes, again, lowered the risk of death. So all of this is pointing in the right direction. These are highly, highly effective procedures or interventions. And again, this tells us that we really need to try and increase awareness and test people who want to be tested so they can know that they have an inherited cancer predisposition and they have choices to improve their outcomes. So the other question we often get is, what about hormone replacement therapy after preventive removal of the ovaries? And again, the bottom line here is a qualified healthcare professional with expertise in medical management is best poised to kind of manage these people, because hormone replacement therapy is not contraindicated. So it's an important consideration for premenopausal patients who don't carry a diagnosis of breast cancer and don't have other contraindications. And premature menopause can cause detriments, and hormone replacement therapy can reduce these risks. And again, we've outlined a section in our NCCN guidelines to address this question, because this is a question that often comes up in practice and is really important to get increased awareness about. Now, looking at follow-up care, again, back to our Florida study, what we looked at in BRCA carriers across the 3 population groups is the rates of bilateral mastectomy as well as salpingo-oophorectomy, so removal of the ovaries and the tubes preventively. What we saw was no disparity across populations in bilateral not in bilateral mastectomy, but in breast cancer risk management. So there were lower rates of bilateral mastectomy in Black women, but when we accounted for, were they getting screening? Were they still in treatment? There really wasn't a disparity. Where we did see the disparity is the salpingo-oophorectomy, or removal of the ovaries and fallopian tubes, where there were much lower rates in Black women compared to the 2 other groups. And even when we looked at other factors that could be contributing to this difference, the difference remained significant. So again, we don't know the reason for this. The thing is, if Black women are getting the same information as other women and are making an informed decision to not have their ovaries removed in the context of a BRCA mutation, that's okay. But we are not certain at this point that they are getting the same depth of information. So again, I think it's important to make sure across all populations that people are getting accurate information to make the best decisions for themselves. So again, looking at our registry-based studies and the subgroup of Black women, what we did in that sub-study is we also did additional genetic testing even after we recruited. So some people already had genetic testing when they entered the study, but everyone was offered genetic testing as well. And this is unpublished data that we've been going through. And really what it shows is, in our study population, so these are young Black women with breast cancer, what we were able to show is that in women who are BRCA positive, the rates of risk-reducing mastectomy, so bilateral mastectomy, were higher, 58%, versus those that were BRCA negative at the time of study enrollment, BRCA negative overall, so about 30%. But when we delved deeper and we looked at those treated pre-surgery versus post-surgery, what you can see here is bilateral mastectomy rates, when women knew about it prior to surgery, were much higher than if they knew about it afterwards. And again, the bottom line here is Black breast cancer patients use genetic testing to guide surgical decisions, which also tells us that we need to do better to improve these differences in testing rates. I think we really need to go towards testing all populations, or making access as equitable as possible across populations, because it seems like even populations with disparities use this information to make medical choices. Now, what I also wanted to go through is the ripple effect of cancer risk. So really thinking about family testing, family communication. So in genetics, families are the unit of care for us. And prior data has suggested only 2 members of families are tested on average, even after someone is identified to have a mutation. And this is really a missed opportunity for cancer prevention. And we already know we're only at the tip of the iceberg when it comes to identifying people with inherited cancer. So just to kind of go through family risks, If the side of the family is not known, then we have to test both sides of the family. So we don't know if mother has it or father has it. Both sides end up being at risk. However, if we are able to test mother or father, then we can say that one side is not at risk. So in this case, mother and her family are not at risk, but father is at risk, so his side ends up being at risk. So again, if we can test parents, that is always beneficial. But again, testing and sharing this information broadly is very important. And when we're thinking about disparities in cascade testing is just a fancy word for additional family testing. And what's been shown through research is that cascade testing rates, defined as at least one at-risk relative having testing, is much lower, so significantly lower in Black patients compared to white patients. And these differences didn't change even when there was no charge of testing policy for relatives through one of the labs that had done this work. So again, I think there is an existing disparity in cascade testing, and that's a point that I think we really need to be thoughtful about. And there are research works that have outlined some of the next steps. And, the bottom line right now is interventions haven't prioritized historically underrepresented and underserved populations. So there are ways of trying to improve upon what we're doing to make things more equitable. Now, there are various different resources that are available to serve to increase family communication, family testing. One of the resources that I think is really wonderful is something called Connect My Variant. And really, it's a free service through a not-for-profit that provides individual family outreach navigation and ongoing support. So again, if that might be of interest, I've put in the website. I've also put the QR code to access this resource. The other one I want to highlight is through my colleague, Kathy Baker, who's the founder of My Faulty Gene. And this is Kathy's story. So at age 30, she had a sister diagnosed with breast cancer at the age of 32. At age 32, Kathy had a mammogram. It was convenient at the time. It was through a mobile bus. It was normal, so she had no plans to repeat this mammogram until age 50. However, at age 42, she had stage 2B breast cancer treated with lumpectomy. She declined genetic testing at the time, even though her oncologist offered it. Oncologist, over multiple visits or yearly visits, kept revisiting testing. And finally, at age 51, she finally got tested and she had a BRCA1 mutation. And she had her preventive surgeries. During her risk-reducing surgery to remove her ovaries and fallopian tubes, she was diagnosed with early-stage ovarian cancer. So again, Kathy is very open about this, and she feels like genetic testing saved her life. So again, these are the types of stories that I think might resonate with people to see, well, how can genetic testing change outcomes? Kathy has now formed this not-for-profit and really has made it her mission to try and improve family communication and increase awareness. And she has a resource called Family Gene Share, through which she's developed a number of patient testimonials. They're short gene-specific testimonials to help educate about genetic testing and sharing information with family members. So I would encourage people to check this out. It's really wonderful what she has created. And then I wanted to talk a little bit about our study. It's called the Impact Study, which is a clinical trial really focused on improving follow-up care after genetic testing for those with a positive result. And really, I'm going to talk a little bit about the trial portion where we tested a family communication intervention and compared it to not getting this intervention. And again, this is just some information about the intervention that we created through through research methodology interfacing with various individuals with inherited forms of cancer. So again, thinking about deciding whether to share genetic test results, planning it, choosing the materials to help share the results, and then review and supporting resources and others' experience. So we have various different worksheets that are available, materials to share with family members, videos about sharing genetic test results with family members, as well as videos about others' experiences sharing these test results. And these are early results. This is unpublished data that I'm presenting, but in over 500 individuals with up to 5 months follow-up, we're pleased to see that the disclosure to at least one relative has significantly increased through this intervention. We're only at up to 5 months. The other piece of this is it's not just about initial disclosure. I think sharing with family members is a process, and that's where I don't know that we've done good enough in terms of ongoing sharing, which I think is important. And we also have done some patient interviews to see what people have liked about the resources that we have offered, and then some of the things that have been barriers. And really what we've been able to see is, well, which are the materials that have been the most well received? Again, this is not something that's been offered right at the time of diagnosis. So I think timing is an issue for our trial because, again, when you're conducting a trial in this context, we weren't able to get people right at diagnosis. Most of our participants are people that were part of our inherited cancer registry. So again, more to come on that, but there are some results that look promising at this point. So, in essence, keeping up with the latest advances is a challenge, and finding resources is also a challenge. So I just wanted to highlight there are several free OCRA, Ovarian Cancer Research Alliance programs for ovarian and gynecologic cancer community. And I've listed them in this slide, as you can see. And again, I would encourage you to check it out. And then with iCare resources for those specifically interested in topics related to inherited cancer, we're very active on social media. We'd welcome anyone that is interested in participating in our registry. But even if you don't want to participate, all of this is available regardless of participation, including access to our newsletters, which we put out every 6 months. So a fall and a spring newsletter where we include guideline updates. In those that are in our registry, as clinical and research updates come up, we will do targeted emails that are gene specific as well. Because again, we recognize that keeping up with what is coming out and what might be relevant is sometimes a challenge. And when I'm looking ahead, just in the context of precision medicine, I think it's going to be a multi-pronged approach with the patient in the center that is going to move the needle. We need to think of the family and the individual, and then overlaid on it the healthcare provider, and then the health system. So again, I don't think it's going to be a one-size-fits-all, and I think we're going to have to think about this at multiple levels in order to be able to support patients the way we strive to. And there are many barriers, even when we're thinking about cancer risk management. There's education and awareness, there's discrimination and bias, access to services, costs. So again, our ultimate goal is improving survival and, reducing risks. So I think there's a lot to do, but I think at this point, we have shown that genetic testing can save lives. And really, the goal at this point is to realize the promise of genomics across all populations, regardless of race, ethnicity, and ability to pay. So with that, I thank you for your attention. In this last slide, I know I went through many different resources, but I've put in the QR codes for the Okra genetic testing program, the Connect My Variant resource, the Family Gene Share testimonials also has a QR code. And then from an eye care standpoint, we have social media. Our handle is @Inherited Cancer, and we have very active YouTube playlist that I put the QR code for, as well as a QR code for our newsletters. So with that, I thank you for your attention.